Now we go to our next, Advances in Ablation Therapy in Atrial and Ventricular Arrhythmia by Dukkipati. He is the Program Director, a Professor of Medicine, Director of EP Laboratory and Cardiac Arrhythmia Services. And this is also a very intricate topic. Things changes quite a bit, and he'll give update, and very expert, our electrophysiologist.
Thank you. I think Vivek Reddy was supposed to give this talk initially, but apparently he has a pressing engagement in Napa Valley on a Friday, so who knows. So he asked me to do this, and I initially was thinking of saying no, then I saw the program, and you see your bosses of the program, you can't say no. But anyway, it's my pleasure to talk to you about advances in ablation therapy in both atrial and ventricular arrhythmias. These are my closures, particularly for this talk. The relevant one is Farapulse, which is a pulse field ablation technology. I could talk about atrial fibrillation and ventricular tachycardia for the whole session, but I decided to limit it to these, what I believe are key topics. For atrial fibrillation, I'd like to talk about the relationship of heart failure, atrial fibrillation, and the potential benefit of ablation therapy, the new kid on the block, a new ablative therapy, pulse field ablation, and an important relationship that's currently being established between atrial fibrillation and dementia and cognitive impairment. So as the first part, when you think about atrial fibrillation and heart failure, through various mechanisms listed here, about 3% of patients with AF will develop heart failure per year, and about 5% with heart failure will develop atrial fibrillation. So what's the role of atrial fibrillation ablation in these patients? Well, if you go back to 2016, there was a relatively large for EP, 200 patients, randomized trial, taking HFrEF patients with persistent AF, and they randomized them to amiodarone or catheter ablation. The primary endpoint in this case was just recurrence of atrial arrhythmias, and this shouldn't be surprising to anybody, AFib ablation was superior to amiodarone. What was surprising was that ablation seemed to be better than amio at decreasing cardiovascular hospitalizations and all-cause death. That was a little bit of a surprising finding. However, we then come to CASTLE AF, which was also a large trial, 400 patients, that took patients with either paroxysmal or persistent AFib, HFrEF, again, EFs less than 35%. They actually were intolerant or actually failed a drug or didn't want to take one, and they were randomized to not another drug, but continued medical therapy or catheter ablation. In this case, the primary endpoint was all-cause mortality and worsening heart failure admissions. And what you see here is the primary endpoint, and the secondary endpoints on the right, and there's a 38% reduction in the primary endpoint with ablation. And as far as all-cause death, 47% reduction, and heart failure admissions, 44% reduction. So I think all this data was supporting ablation over antiarrhythmic drugs, medical therapy for atrial fibrillation. And those two studies, along with several smaller studies and a meta-analysis published by our group here, showed that all-cause mortality is reduced by 48% and heart failure hospitalizations by 40%. Now, these positive data was reflected in the most recent iteration of the atrial fibrillation guidelines, which is the European guidelines. And if you look on the right side, if you have paroxysmal or persistent atrial fibrillation, heart failure with the reduced ejection fraction, obviously we consider patient's choice, but for the first time, catheter ablation is listed as a class 1 indication. So first-line therapy for these patients with HFrEF. If that wasn't enough, most recently we got the CASTLE HTX, which is a trial which was published in the New England Journal this year. And this is actually a single-center study from Germany, and it's open label, investigator-initiated. They randomized about 200 patients, 1-to-1, ablation versus medical therapy. And these are actually considered end-stage heart failure patients. They were potential candidates for heart transplant. They had ejection fractions less than 35%, at least class 2 heart failure, and they had to have devices, either loop recorders, ICDs, pacemakers, or whatever to record for atrial fibrillation. The composite endpoint, which is the primary endpoint, was all-cause mortality, LVAD implantation, or urgent heart transplantation. These are the demographics of the patients. The majority were either class 3 or 4 heart failure. The 6-walk distance at about 300 meters, a 6-minute walk. About 45 to 50% were on amiodarone. These are the rates of Entresto and SGLT2 inhibitors are shown on the bottom. During follow-up, this actually, at the first year post-enrollment, the DSMB recommended immediate cessation of the medical arm therapy arm due to clear benefits of ablation. And if you look at this primary endpoint, I mean, these are astonishing hazard ratios. The primary endpoint, the hazard ratio with ablation, 0.24, death from all cause, 0.29, implantation of left ventricular assist device, 0.09. Really dramatic. Whether you really believe this or not, I think it just adds to the body of evidence. Sean, I'd be interested in hearing your opinion about this later, perhaps. If you look at the left ventricular ejection fraction in patients who undergo ablation, there's improvement in that with medical therapy, not really much improvement. In terms of atrial fibrillation burden, which is probably what we should be following more than just AFib recurrence, you see AFib burden decreases with ablation, and with medical therapy, it seems to maybe decrease a little bit, not much of a change. So at least based on that, I think for your patients with heart failure, HFrEF, I think you should strongly consider catheter ablation as first-line therapy rather than trying one antiarrhythmic and cardioversions, another antiarrhythmic, and going down that path. And I'll tell you some of the bad things that can happen down that path in just a bit. So I'm going to shift gear and talk about catheter ablation. The new kid on the block is called pulse field ablation. When we do catheter ablation now, what we do is we use thermal injury. It's radiofrequency energy, which heats up tissue, or you can use a cryoballoon, shown here in this illustration, to freeze the tissue. It destroys tissue, and it's indiscriminate in the type of tissue it destroys. So not only do you do the pulmonary vein isolation and affect the cardiomyocytes, you can get phrenic nerve injury, you can get pulmonary vein stenosis and esophageal injury as well. And so that's one of the drawbacks of thermal injury. This is a MRI just here to show you the relationship of the left atrium to the esophagus. It's right against it. So if you're ablating in the posterior wall of the left atrium, you can potentially cause damage to the esophagus. So when we do thermal ablation, the whole point is to balance the safety and efficacy. And we do that every day, all the time, constantly with every lesion in the EP lab. With pulse field ablation, it's a completely different energy source. What you're able to do is put a catheter in the pulmonary vein and deliver an electric field across the cells. And that destabilizes the cell membranes and actually pokes holes in it. It's called electroporation. And the cells leak out their contents and die by apoptosis. The good news about that is the energy required to actually ablate myocardium is one of the lowest. So you can perhaps selectively ablate myocardium while sparing surrounding structures, such as nerve tissue, vascular smooth muscle, esophageal smooth muscle, so less potential collateral damage, and it can be done very quickly. This is a MRI, delayed enhancement, 3 ablation technologies shown here, cryoballoon on the left, radio frequency on the right, and pulse field ablation on the actually radio frequency in the middle, pulse field ablation on the right. What you see is delayed enhancement of the esophagus following ablation with the 2 thermal modalities. Whereas pulse field ablation, you see relatively smooth, so it does not affect the esophagus. Okay. This is how it's done. This is one of the catheters. It's a one-shot device. You make it in a basket, or you can change the shape into a flower, and you advance it into the vein over a guide wire. You deliver a simple set of microsecond electrical pulses, and the electrical potentials in the veins go away. And just like that, by the time you blink, the vein is isolated. So very quick. The results of this technology, comparing that to thermal ablation, was just published in the New England Journal by my colleague, Vivek Reddy, and also William Wang, who really enrolled a lot of patients in this trial. It was multi-center, randomized, single-blind, non-inferiority. It randomized patients in a 1-to-1 fashion to pulmonary vein isolation using PFA or thermal ablation. And the thermal ablation is a center could use radiofrequency if they want, or if they preferred, they could use cryoablation, but a center was assigned to each type. The inclusion was any paroxysmal AF patients and the refractory to any class 1 to 4 drugs, so beta blockers even. And the primary efficacy endpoint was a composite of initial procedure failure, recurrence of atrial arrhythmias after the blanking period, if you use antiarrhythmic drugs after the blanking period, if you needed to do cardioversions after the blanking period or a repeat ablation. There's also a safety endpoint, which I'll go through as well. These are the demographics, 300 patients in each group. For an ablation study, I think we can agree that's a pretty sizable amount of patients. These are a standard paroxysmal cohort of patients, 62 years old. About a third of patients were female. CHA2DS2-VASc score mean of 1.7. These are the other comorbidities, normal left atrial diameters, and these are the class 1 and class 3 drugs, 37% and about 25% respectively in the cohort. And these are the results of the study. So acute success, pretty much everyone got acute pulmonary vein isolation, 99+%. If you look at the procedure times, you see that the procedure times are less, significantly less with PFA compared to the thermal ablation. LA dwell time, the ablation time. The fluoroscopy time is just perhaps a little bit more just because this technology doesn't require a 3D mapping system to use. So you may require fluoro, but you should consider these procedure times in the context that many of the operators doing these procedures have never used this technology before. And still yet they were faster than doing radiofrequency ablation. In terms of the primary effective endpoint, there was really no difference, 73% versus 71%. If you look at the composite the composite safety events, it was 2% and 1.3%, no statistical significance between the two. There was 2 cardiac perforations and tamponade, none in the PFA group, none in the thermal group. There was 1 death, which I'll come to. That was a patient who had the cardiac tamponade. And there was 1 stroke in the thermal group and 1 TIA in the PFA group. When you look at the death, you got to ask yourself, well, is that related? You had 300 patients and you had 1 death. What's going on? And so you can look at where the catheter has been approved is Europe since March 2021, and they have 24 centers and a registry of 77 operators with about 1,500 procedures. And when you look at the rate of mortality in that, with this technology, it's about 0.06%, which is, I think, in line with the other radiofrequency ablation trials as well. So the third thing, and I find the most interesting thing, is about atrial fibrillation and the relationship to cognitive decline and dementia. There is some data about this, and we're learning more and more about this. There's 2 potential mechanisms. One, if you have AFib, you can have micro and macro emboli and bleeds and result in cerebral damage, to which case anticoagulation becomes very important. You can have cerebral hypoperfusion from the atrial fibrillation itself, which can cause damage from just the hypoperfusion, and it may be beneficial to restore sinus rhythm and target strategies to improve cerebral perfusion. So what really happens when you have atrial fibrillation, you're on anticoagulation, are you protected? Everything's all good, right? Well, according to Swiss AF, not necessarily. So you have 1,200 patients here, okay? 90% of them are on anticoagulation. 19% had a history of stroke or TIA. They followed these patients for 2 years, but what they did was MRIs and cognitive testing. On these patients, who were a lot of patients taking anticoagulation, 2.3% had clinical stroke or TIA. On MRIs, 5.5% had new lesions. 85% of these were actually silent, and 88% of those patients who had these were on anticoagulation. And these overt or silent brain infarcts actually correlated with cognitive decline. Can AFib ablation do anything perhaps to mitigate that? Well, you can lose not the best of data, but a propensity match data from Swedish Health Registry, several thousands of patients, like 2,500 in each arm, medical therapy versus catheter ablation. These all patients were high proportion taking anticoagulation, 80%. And with ablation, there was a reduction in ischemic stroke, 31%. So there may be a benefit beyond just anticoagulation with ablation in terms of cerebral emboli. What about perfusion of the brain? Okay, so this is a study of 2,000 something patients. They did phase contrast MRIs. Of these, most of them did not have AFib. So some had AFib and some had persistent AFib, paroxysmal and persistent. So when you look at the brain total cerebral flow, what you find if you had no atrial fibrillation, you had the highest, presumably normal. If you had paroxysmal AFib, you had less cerebral perfusion. And if you had persistent AFib, you had the worst cerebral perfusion. So what happens if you restore normal rhythm in these patients? So this is a cardioversion study, same kind of phase contrast MI. They took 44 patients. They did MRIs pre-cardioversion and 10 weeks post-cardioversion. And they broke them down into two groups. So you did the cardioversion. The sinus rhythm group are the ones who maintain sinus rhythm. The atrial fibrillation group are the ones who had recurrence. And this is what you see. This is before cardioversion. So this is diminished cerebral perfusion. And after the cardioversion and AF recurred, you really didn't have much improvement. And as a matter of fact, it looks like you had a little bit of decline. Whereas if you were able to restore sinus rhythm, I think you can see here that cerebral perfusion is much better. So leaving patients in just AFib all the time may not be the best strategy. Maybe, yeah, I think it's come time to become even more aggressive than we have been historically in restoring sinus rhythm. This is to show, well, what effect does AFib ablation have on cognitive function? So this is just a study that I'm going to show you. They had two groups, 308 patients undergoing ablation, 50 controls. And they did cognitive assessment, baseline 3 months and post 1 year. And these are the MoCA scores, Montreal Cognitive Assessment scores. And you see with the control, it actually goes down a little bit. You can say it doesn't change much. But with these, with ablation, the cognitive function goes up. And the people who respond best are the ones who had pre-RFA cognitive dysfunction. They actually do much better afterwards. So, scary. So this is, so you look at this study and you look at cerebral perfusion with catheter ablation versus controls. With ablation, the perfusion goes up. With controls, in 6 months, the perfusion goes down. That's actually very scary. You're just managing these patients conservatively. 6 months later, their cerebral perfusion is worse than it was when you first saw them. So I think this data is compelling, but I do think we need to get this evaluated in randomized prospective trials to better elucidate this. Okay, the last part is VT and VF, okay? So we're going to talk about some recent three, randomized clinical studies that have affected how we do VT ablation or indications. And the last one is advances in ventricular fibrillation, which I think you'll find interesting. So when you look at all the clinical trials, randomized multi-center clinical trials, looking at the role of VT ablation, this is it, okay? There are 3 of them that do ablation at the time of ICD implant when patients have had spontaneous VT or VF. There are ones that in patients who had ICD, the Berlin VT, where they come in with VT, VF, and you consider an ablation. And there's one who's already had a defibrillator, who's already on amio, and then they come in with a shock. And if you look at these studies, none of them are actually designed to evaluate drugs versus ICD or ablation. The primaries are ablation versus control, ICD plus ablation versus ICD alone. And except for VANISH, where the patients were already on antiarrhythmic drugs, and the strategy was to evaluate ablation versus escalation of the antiarrhythmic drugs. So none of these are designed to evaluate versus amio, for example. The other thing you'll notice that is all of these patients were ischemic cardiomyopathy patients. So none of this studies or data is relevant to non-ischemics, ARVC, for example. Of all the data from this study, all you can gather is that there is no mortality benefit with VT ablation compared to the controls, whether it's ICD or whatever. There is, however, a decrease in VT. Okay, that's all the VT studies show, no mortality benefit. Now, with this year, from 2022, we've had 3 trials. The first one is Partida. Okay, it's a 2-phase study. They took 517 patients who were getting an ICD at the time of defibrillator implant. They could be ischemic or non-ischemic, so inclusion of non-ischemic. They put them in a registry. When they got a shock, which was 11% of them, they were reconsented and randomized to ablation or standard therapy. Again, not any specific drug, but standard therapy. This was stopped at the first interim analysis, and I'll show you why. The primary endpoint of all-cause mortality and heart failure hospitalizations favored ablation dramatically, okay? Look at the number of patients that are enrolled. It's even hard to believe, like 50 patients, and you see this kind of effect. So you really got to delve into the data, and we'll go into that. All-cause death was really what was driving this, not just, and not worsening heart failure necessarily. Okay, so here's the events, safety events, okay? There were 8 deaths, all cause in standard therapy, 0 in ablation, 0 cardiac deaths in ablation, and 3 cardiac deaths in standard therapy. So when you look at the 3 cardiac deaths that happened, all of these were related to VT recurrence. So you can, this was consistent with the hypothesis that ablation reduces VT. And so if you have VT, you're more likely to die for these reasons. But these 5 non-cardiac are really hard to explain as being due to any ablation. For example, malignant tumors, sepsis are unknown causes. So, you know, you got to take this with a grain of salt, but the trial was stopped for those reasons. There was another trial which actually randomized ischemic cardiomyopathy patients at the time of their first ICD shock to ablation or amiodarone plus beta blocker. If they couldn't tolerate amiodarone, they got sotalol plus beta blocker. If they couldn't tolerate beta blocker, they got amio. And this is what they saw. This is the composite endpoint: cardiovascular mortality, ICD shocks, heart failure hospitalizations, severe treatment-related complications. Clear benefit of ablation over antiarrhythmic drugs, okay? And, but this is what, when you look at the components of the primary endpoint, this is what it's all driven by: severe treatment-related complications. There were a lot more in the antiarrhythmic drug arm. So what were these? Well, they got put on amiodarone, and these patients came back with incessant VTs, slow VTs, below the detection rate, in heart failure. So these are the treatment-related guidelines. So when I see patients in the CCU are getting loaded with amio, I always think in the back of my mind, I'm going to see this patient later. It's going to make the VT come back slower, and he'll eventually get ablated. So it's better to not kick the can down the road if you can. And the third study, which also included non-ischemic cardiomyopathy randomized study, was PAUSE SCD, first-line VT ablation with ICD implant. And this included post-MI, dilated cardiomyopathy, ARVC patients, substantial portion actually, 30% and 35% DCM, ARVC respectively. Ejection fractions less than 50%. They had monomorphic VT and indication for ICD. So they either got the ICD or ICD plus catheter ablation. And the primary endpoint, again, was strongly favored ablation, VT recurrence, cardiovascular death, or hospitalizations, and really it's mainly due to VT recurrence that this was seen. And that one thing I want to point out, post-MI patients and ARVC patients actually do very well with catheter ablation. Dilated cardiomyopathy, maybe not so much due to intramural scar, but ARVC, high rates of success, post-MI patients, high rates of success. And I think that's what's reflected in this trial. Okay, the last couple of minutes I want to spend on this, which is ventricular fibrillation ablation. which is our understanding of ventricular fibrillation is increasing, and it's due to pioneering work by Michel Hasseguer, who also was pioneering work for atrial fibrillation. What he did was he took 54 patients with ventricular fibrillation and structural heart disease, ischemic cardiomyopathy, hypertrophic cardiomyopathy, dilated cardiomyopathy, and Brugada syndrome. This is very complex, but I think you'll understand the concepts quite well. So what they did first is they tried to identify abnormal substrate. So how do you do that? You get imaging, MRIs to see where scar is, or you do voltage maps, see where abnormal electrograms are, or where scar is. Next, you either have VF in an electrical storm, some PVC triggering it, or you induce VF, and then you map these, where the trigger's coming from. So you have catheters in the heart. You can see where the PVCs are coming from. You have body surface ECG. You can see where the drivers are from. And that's what they did with this study. And what they found, and I'm just going to summarize it here, is basically when VF is initiated, the first few seconds of ventricular fibrillation is organized, okay? And that's driven by rotors, these areas coming from substrate-based rotors. And those rotors eventually disseminate and it becomes disorganized. And that's the lesson from this. And I think you'll see that here. Here's a patient here who's in VF, and you see here it looks, I wouldn't say as disorganized as this. I think we can agree this is a little bit more organized. And you can see here the VF tachycardia cycle length, as they call it. As it becomes lower, it becomes more disorganized. And I see that's what's going on here. And this is a measure of QRS dispersion. It's becoming more dispersed. So in this first few seconds, it's organized, then becomes disorganized. And they found that these drivers for this organization are coming from an ischemic cardiomyopathy areas of scar tissue. Okay, so myocardial scar, areas of abnormal voltage, dilated cardiomyopathy. In Brugada syndrome, he found it over in the right ventricle where we would expect, the right ventricular outflow tract. Okay. One other thing you see here in hypertrophic cardiomyopathy patients, especially, you see Purkinje drivers. Okay. So here he induced VF. You have VF here. What you see here are Purkinje potentials, and there's an asterisk before each QRS. Okay. And what you see of interest here is it's much faster than the QRS. See, it's driving the QRSs. So these are reproducible. So these drivers, these Purkinje targets, they're reproducible. They actually accelerate, and then they cause the disorganized VF. So these are triggers. And what he found most interestingly is that you can ablate these substrate and these triggers, and look how well they do over time. Now, you may not get all of it in one shot, and 61% had no VF at 5 years. That's pretty impressive. And 22% had one VF recurrence. 17% had greater than 2. But overall, I think, I won't go through my summary slide, but I think what I've shown you here is that electrophysiology is definitely advancing, and it's an exciting time. So we'll answer questions during the...